Welcome to Fuller Butz, a behind-the-scenes plastic surgery podcast. Yes, you heard that right. Join your co-hosts, Dr. Sam Fuller and Dr. Dan Butz, board-certified plastic and reconstructive surgeons, on an exclusive full-access pass into the world of plastic surgery. Combining their expertise and training, Drs. Fuller and Butz will share medical insights, detailed explanations, and lighthearted humor to keep you entertained and informed. We're certain you'll become passionate about the plastic surgery specialty, and between debunking myths, uncovering truths, or just making you laugh out loud at their perspective on this creative and artistic field, we've got something for everyone. From tummy tucks to Botox and mommy makeovers to surgery do-overs, the Fuller Butz Podcast will surely satisfy your podcast fix.
Welcome back to another podcast of the Fuller Butz behind-the-scenes look at plastic surgery. I'm Dr. Butz, and I'm joined with Dr. Fuller, your co-host. Dr. Fuller, how's everything going? Do you have a busy day today?
Busy day, yeah, full gamut. Started with a mommy makeover, so breast augmentation with lift, the internal bra, abdominoplasty, rectus plication, flank liposuction. Took out 25-year-old implants, a full explant with capsule. They were prepectoral, so it was pretty cool taking out the entire capsule and then cutting it at the back table to kind of open up that chalky pocket that was there and take a look. It was actually a dual implant with both saline and silicone, which is unusual to see. So I was able to inspect that.
Yeah. Send that to the historical museum.
Yeah, it was nice, and was not making the patient sick or ill, but came up on their mammogram, was old. It was time for them to be removed. Did not desire any replacement, and so was able to just do a lift for her. Went over to the office, saw some nice consultations, some post-ops, some new patients, and then did a small procedure upstairs in the office under local. So all in a day's work. How about you? How are you ending up the week?
Pretty casual Friday. My Fridays are typically just clinic, so a bunch of post-ops, some pre-ops, consults, so very busy clinic day, but one small procedure, but nothing as exciting as 25-year-old implants, dual saline silicone. I've never seen those before.
Yeah. And so, on our drives home, on our phone calls, we're always talking about ways to educate our patients to kind of get through some questions that we seem to be answering each and every consultation, really for efficiency for us. We're not repeating ourselves, almost to have these questions answered pre-appointment. And if we had a nickel for every time we answered these questions that we're about to answer on this podcast, we'd have a lot of nickels. So we thought it would be worthwhile to have a podcast on some of the most frequently asked questions to us as plastic surgeons from our patients, and see if they can help just educate, spread the word, demystify, and provide some real-time answers to the questions that are on our patients' minds.
Yeah, so we kind of talked about some different things we hear a lot of and try to summarize them in kind of common vernaculum. But we get a lot of questions throughout the day, and these are kind of some of the big hitters. So I'll start you off with the first one, Dr. Fuller. How painful is this surgery really going to be?
Yeah, so patients are anxious and nervous leading up to surgery, and one of the probably top 2 or 3 reasons is the level of pain that they are anticipating, worrying about. Went on Reddit, went on, Real Self, read something, and are worried about how they're going to experience pain post-op. Essentially, what I tell patients is that pain is very subjective. So it really depends on a number of factors. Have they had previous surgeries? Have they tolerated that? Are there pain medications that they take more reliably? What is their combination of anxiety, preparedness, their age, their medical history, the actual procedure that they're having, but to not skate across it and to gloss over it. Essentially, I tell them that it's in different phases. So, for breast surgery, really tends to be pretty well controlled. I inject local numbing medicine, so I instruct them that they're going to get pain medicine both through the IV by our anesthesia colleagues as well as on the surgical site. And then for the first 24 hours or so, usually encourage them to try to stay ahead of it, to have some scheduled medications. Typically, it's an ibuprofen or NSAID, as well as I use Norco as part of my protocol. And then to try to titrate down. So with the goal being within 2 to 3 days, being off of narcotic pain meds entirely and really just taking over-the-counter Tylenol and ibuprofen. In addition to that, the surgical bra is used as a pain measure. It helps for comfort, compression, as well as ice packs more higher up off of the incisions in the armpit, on the collarbone. Don't like them directly on the incisions or the nipples from a blood supply standpoint, but try to go with a multi-prong approach to deliver pain control, trying to put them at ease that I've had patients go through it without any narcotics whatsoever, and some of them just take Tylenol, ibuprofen, but ultimately tell them, it's not the time for them to be a hero. If they're in pain, they should take something about it. But usually after the first 24 hours, very tolerable, social within 2 to 3 days, potentially going out to dinner, picking up their kids from the drive-through for school pickups, and ultimately driving themselves to their first post-op appointment. From a breast surgery standpoint, since we're pretty much just breast and body plastic surgeons, what's your protocol, or how do you approach a breast patient who's talking about how much pain am I really going to be in? I'm worried about that.
Yeah, breasts are generally quite a bit easier than, let's say, abdominoplasties. And like what you're describing, it's very similar. I'd really say it's very subjective. Lots of patients don't take any narcotics, but most probably take it 1 to 3 days, ideally transitioning over to ibuprofen Tylenol as quickly as you can. And again, when we combine these things, they often forget they even did the breast, and they're kind of all the attention goes to the abdomen. It's kind of one of the benefits of combining these surgeries into the traditional mommy makeover or some sort of combination. You got to get one recovery for multiple things. And even abdominoplasties, I have some patients come in and they're like, that was a lot easier than I expected, especially with the expiral nerve blocks, drainless approach. I try to over prepare them. So I'd rather have patients come in saying that was way easier than you told me than come in saying you really misled me. That was terrible. But there's always outliers. Some patients do require a little bit more pain medication, but for the vast majority, after that first week or so, they're saying, oh, that wasn't as bad as I kind of read about on Reddit or heard about from my friends. I think largely due to these kind of more modern techniques with the long-term nerve blocks and drainless and all these things, we're kind of implementing the multimodal approach with pre-surgery medications and kind of hitting it early afterwards as well.
Yeah, I honestly worry less about the patients who ask about pain, who say they're worried about that because they're thinking about it. They're trying to predict that. They're trying to provide some sort of expectations for themselves. And so really talking them through that. It's really the patients who, maybe are more excited, gleefully, which is great, optimistic, but then are expecting no pain, this to be a breeze. You really want to say, hey, this is still a surgery. There's still an intervention that's going to be had. Your body's going to react to that in some way. So try to get through the first phase of let's just get through the first day. Usually call them the next day, my patients, and just make sure that they're doing well. You're my staff member, see them at 1 week. Usually things are pretty good for the first several weeks. And then I do anticipate some nerve regeneration. So as the nerves start to wake up, sometimes they can get some zingers. Sometimes as they're becoming more active, they can have a little bit more pain. Sometimes on the lateral aspect of the breast, the nipple sensation starts to wake up. And so I also try to provide that forward thinking expectation that there's going to be different levels. Sometimes it's good for a few weeks and then you're kind of wish it was numb again as the nerves start to wake up from that process. Just to reassure them that it's a lengthy process, but something that's very tolerable and very worth it at the end as they're excited and looking in the mirror and loving their results.
Yeah, I think that's a big thing is preparation. So it's not a surprise. So you're kind of giving them that expectation ahead of time to what to expect. And I think you're kind of jumping into one of our next questions is kind of how long is their downtime really? You kind of touched on it, and it is a process, right? You don't have surgery one day and it's 7 days, you're back to 100%. You want to kind of, how do you prepare patients for what to expect for that, the duration of how long they're down for, and what that means?
Yeah, and maybe we'll switch to abdominoplasty or tummy tuck for this since we used breast as an example for pain. For each procedure, set expectations. I usually see them for a pre-op appointment where I'm talking to them, building up, leading up to surgery, taking some supplements, trying to ensure them that they have to invest in the recovery just as much as the surgery day. That's a term I think you used last season for an episode, but really stuck with me. And usually say that they can get back up to full speed a lot faster if they just shut it down and rest and just follow the restrictions that are there and in place for a reason. And so, what that means, pain aside, just in the recovery, is inform the patients that they can type, text, hair, makeup, wipe their own butt, put their own clothes on immediately, the same day as surgery. And that's usually kind of eye-opening. They're excited to know that they're not going to be as dependent on somebody else for that. Inform them that they're likely going to be sleeping in a semi-upright position. The transfers in and out of bed and chairs may be difficult after a tummy tuck for the first day or so as they get used to it. But it's a lot easier now that both you and I are doing tummy tucks in a drainless fashion. So there's just less stuff hanging off of them. As they get through the first 3 to 5 days, usually encourage them to transition off of pain meds and then start to stand up straight, still on a 5 to 7 pound weight restriction for a week. See them at the 1 week appointment. Restrictions go up to 10 to 15 pounds from 1 week for a total of 5 additional weeks. And at 6 weeks is really when we take the training wheels off here at my practice and allow them to start to lift, return back to, workouts, gym memberships. Everything is a bit subjective. Sometimes it's a little bit earlier, but I would say 6 weeks is a good expectation, not to be back up to their full speed, but to be able to not worry about damaging the post-surgical result, because there's a lot of stitches, there's a lot of suturing. They've invested a lot of money into these procedures. They have to invest some time into it as well. How about you? As far as how long will it really take? I have some patients who talk about returning back to work for desk type of activities versus somebody who's on their feet, say a teacher or a hairstylist, a dental hygienist. What are you telling the variety of patients who come in based on their activity level? The most extreme I've had was a FedEx delivery person in which she needed the full 6 weeks off of work because she was lifting heavy packages and boxes. But I think everything short of that, it's a lot earlier than that as far as returning back to work.
Yeah, typically I say the average for someone who's driving into an office and kind of interacting in like an office environment is typically about 2 weeks. If you're able to work from home, a lot of people are logging on, especially you have tummy tucks, probably maybe even 3 to 4 days when they're starting to get off the pain medications, but probably not sitting at a desk for a full day quite yet. And some people can bounce back really quickly and they're like ready to go in a week. That's super, but I'd rather prepare for 2 weeks and have you go back earlier. 3 weeks, sometimes if you have a more active job, but maybe if you're on your feet all day running around dealing with kids in the daycare, a teacher, it kind of depends on again the level of what age and things like that. So we often discuss that and what kind of makes sense for them. But I often break up recovery in kind of 3 different phases. There's that early phase where you're probably spending most of the time in bed taking pain medications, and that's probably again 2 to 4 days for like say a makeover tummy tuck. But you're slowly kind of doing more and more throughout that time frame. Then it's kind of the intermediate phase where you're avoiding heavy lifting, not doing too much. That's kind of that 1 to 2 weeks where you're being super careful. Then I kind of we all have different ways of doing it, but like between 2 and 6, you can kind of start to explore things a little bit, push the limits, but kind of be just still cautious in terms of testing things out before you really put all your weight into it. Then at 6 weeks, you kind of really know true restrictions, but even at 6 weeks, you're not 100%. You want to again ease back into it, listen to your body. If it doesn't feel quite right, kind of modify and adjust. So I think those are kind of we all have different ways of describing it, but similar general guidelines and expectations where most people are almost 100% by 6 weeks, but still have little things they gotta work through still, nerves and things that are healing.
And so a double bonus question add-on to this is compression garments. So we know that compression garments are key. A common question of like, how long is recovery is how long do I need to wear my compression garments? So what do you tell patients? And also, how do you describe like the different phases of, being more swollen, potentially needing a larger compression garment, maybe even the same size or larger than they actually are, despite having a tummy tuck? And then when do you anticipate them maybe downsizing or switching to something that's smaller from a post-op recovery standpoint?
Yeah, so I think I like compression for 6 weeks, I tell them. And I think the first tummy tuck, I'm like the first 2 to 3 weeks, I want it pretty aggressive. And then they can start to kind of, tailor it depending on how they're feeling. And kind of lighten it up, see how it feels. If they're like, oh, I feel swollen with this lighter compression, maybe ramp it back up. There are these stage 2 compressions and kind of really even more aggressive devices that some people will recommend for 3 to 6 months. I think that kind of just becomes shapewear and isn't really changing the result as much. So I don't think we need to torture our patients for that long of time. So I really think the first 3 weeks we want to just focus on minimizing general swelling, minimize potential for seromas, control that, and then between 3 and 6, kind of easing off it a little bit. And ideally at 6, and kind of tapering off, kind of like getting back to exercise, see how your body responds to it. Maybe use it on and off as you kind of transition back to without it, but it doesn't need to be as aggressive, in my opinion.
So when patients ask me, okay, I'm at 6 weeks, can I wear it longer? I usually say, especially in the wintertime, yes. Like the longer you wear it, the better it's going to be, conceivably, as long as it's comfortable. Added compression beyond 6 weeks, I still think has some value. Diminishing returns on investments, another 4 to 6 weeks beyond that. But if someone is asking you, should I still wear it if I want to at 6 weeks? Are you telling them yes or no?
Yeah, I don't think there's any harm in it. I don't think it really probably helps all that much in the long run. But if they're feeling like they're swollen, or they're after a long day they're swollen, sure, why not? It doesn't hurt.
And then what about lipo boards? If somebody brings it into your office and say, can I put this board on my belly or my flank? What are you telling them?
I don't like them for tummy tucks. I don't mind lipo foam for liposuction in certain areas, but the boards, I think, are too stiff and can sometimes cause irregularities in and of themselves if they're not kind of placed properly. So I'm a little more conservative on those. What are your thoughts?
Yeah, I just haven't had a great experience with them. I feel like I always get a complaint. Oh, it was bothering me, it was digging in, or, is there some issue with it, made it itchy or had a rash or something. So it's not something that I encourage people to get. And so, yeah, it's not part of my protocol routinely. Another question that we commonly get is, will I be safe during the surgery? Is anesthesia safe for me? Should I have it under local? Do I really need a general? How are you answering these questions for patients who are anxious, about the anesthesia for their elective surgeries?
Yeah, this is a common question we get a lot of times. This is the first surgery someone's gone under, and I think we've had an entire episode kind of dedicated to anesthesia, different types of anesthesia. And I think unfortunately, there's a lot of non-board certified plastic surgeons kind of utilize local anesthetic or non-general anesthetic as like a selling point because it's safer. But in reality, if you're using high levels of lidocaine, tumescence to try to numb patients, it actually becomes more dangerous. So I tell patients that in general, again, assuming you're a healthy individual, we do a lot of pre-surgery kind of testing protocols to make sure we're not overlooking potential risk factors for general anesthesia. It's most likely safer to do a bigger liposuction combination surgery and get a better result more comfortably, more efficiently under a general anesthetic. So I think hospital credentials matter, plastic surgery training matters. You have to do your research, but a lot of times if someone's really pushing more a wide awake approach, there might be a reason for that. So I think general anesthesia is very safe. We take a lot of precautions to make sure it's safe, and we try to just emphasize that in general. How do you approach that?
Very similarly, I think it's healthy for someone to be nervous or anxious leading up to a surgery. It tells me that their brain is, thinking about the risks and benefits and alternatives and everything that they should be thinking as they're making an informed decision. I think my female patients tend to feel a little bit guilty, like, oh, I'm doing this. Is this for me? I'm trying to just, feel better, self-care, that sort of thing. And I try to just, squash that and say that it's safer for them to be under anesthesia having surgery than it is sometimes to be driving their car on an icy road or to be in, certain situations just in real life. There's, some anesthesia study that shows that it's more dangerous to be driving to the hospital than it is to actually be under the anesthesia for the surgery. So, we have extremely qualified, safe anesthetists. We are both you and I, board certified plastic surgeons. We follow nationwide protocols and algorithms. Oftentimes it's safer to have control of the airway, to have IVs and medications on board to keep them safe and comfortable than it is to be in a closet someplace doing it under straight local, which sometimes doesn't always lend itself to being the safest outcome. So there's no true statement that I can make that's going to totally erase all of the worry for that. But it's clear that in today's age, 2026, anesthesia, as it is in our practice, is an extremely safe adjunct, and it's there for a reason. It allows us to provide excellent results in a very controlled fashion.
Yeah, and a lot of times I've seen a lot of consults for revisions of liposuction done or just local, and the patients often describe pretty unpleasant kind of experiences, and also not getting a great outcome. So you really want to make sure they're comfortable and getting that result in a very safe manner. Speaking about results, another common question is, will this look natural? How do you think about that perspective when someone asks you if their breast augmentation is going to look natural?
Yeah, it's a great common question. Patients always use some buzzwords or terms like they just want to have it look natural. They want it to look even. They want it to be, normal. And all of those words to me are not red flags, but it just allows me to ask a follow up question of like, what does natural look like to you? And so, even more so, I'm encouraging patients to explain that. It's hard for us to guarantee cup or bra sizes for that. But I've, even in the past year, I think of several patients who said that they wanted a natural result, but they bring in goal pictures that look extremely, to me, what would be augmented or fake appearing as far as the breasts. And so it's not like there's anything wrong with that, but I just need to make sure that we are aligning with our goals of the results with the patient's goals. And so when somebody says, well, will I look natural? I usually pull up my website, honestly, and pull up the gallery after I take their measurements and scroll through and have them say yay or nay. Like, does this, is this the result that you want? Is this too big? Is this too small? And it helps me frame in their mind what they are trying to say as far as a natural look, because things can look very perky, can look very rejuvenated, but also can look very natural. For my part, how I offer them the natural result is describing the technique that I use, the use of an incision that's underneath the breast, which is safe and effective, the ability to control the pocket for the implant, allowing the manipulation of the tissue, the internal bra, if I'm using that, to allow things to be natural appearing and what they want. But ultimately, I need to gather more information, more data on what that term natural means. What is your approach to answering the question of, oh, I want to look natural?
Yeah, I mean, I would say it's natural is definitely in the eye of the beholder. It's very subjective. So having those wish picks is really helpful because and we're probably biased. We probably can pick out what might not be actually natural better than the average person. Um, but that might still look very natural to a lot of patients. So try to take out my bias and just really try to hone in on what the result they want is. And when we're sizing them off, I'm like, you could get a great result at 250, you could get a great result at 350. There's obviously a lot of spaces in between there. 350 is going to be more enhanced than 250, but probably still look fairly natural depending on kind of tissue coverage and things like that. So picks are definitely very helpful for that. Trying in sizes, thinking about all those things are part of that process. But
Yeah, I think
certainly
that's
it's
a great,
not a one size fits all.
usually go through implant sizes across 2 visits. So their initial visit and also a pre-op visit. In my practice, really measure twice, cut once, and really have them try the different sizers on to hold up and see, does that feel natural? Does that look natural to you? I try to use other terms too. So more, kind of use the term ballerina body, more athletic. Do you imagine yourself working out, doing planks? Is this going to get in the way versus, do you want to really fill out, a certain dress, a bathing suit, that sort of thing? And I remember us talking about this in seasons past, how you sort of mentioned that there's reasons for a push-up bra, and if you want things to look a little bit less natural, there's clothing and there's bras that can do that, and if you want to have a more natural look at rest, then that can be achieved. And quite honestly, especially with some of the patients who need a lift as well, I kind of go through that where like certain ages or certain appearances, it can be very natural to have the breast be lower. But if you were looking for that refreshed look, you want the breast tissue, the nipple, to be at the center point of the breast. A lift can give us a very nice resetting of the clock that may change time, maybe looks a little bit less natural than somebody who's their age, but maybe the desirable result. And it's just really achieving what they want their breast to look like, terms aside.
Yeah, you can always dress them up. You don't want to have to always be hiding them. Sometimes, especially with moms, lots of kids. They don't want to have to be covering them up, but it's easier to dress them up then. You kind of touched on this, with the lifting, resetting the clock in terms of how long these procedures, these results last. Do they truly kind of expire at a certain time? You only get 5 years out of them, 10 years out of them. What are your thoughts on that when it comes to, let's say, breast augmentation, a breast lift, or a tummy tuck?
For breast augmentation, I usually start by saying that the implants are not lifelong devices that are meant to be swapped out or exchanged, typically every 15 to 20 years. And during that time, our arch rival, our worthy adversary, gravity, is going to be working against us. And so usually it's around that time where we can reassess and determine how gravity, how time has changed their bodies. If there's significant weight changes, weight loss, we see lots of patients who are on skinny shots or have weight loss. May cause the breast tissue to droop down and become lower. It may cause their breast volume to be lower, and so I would say that the goal would be, especially with the internal bra, the techniques that we're utilizing, I want that breast surgery to last until the implant is due for a swap out. So I want that to last the next 15 to 20 years, at least. It's in many cases where, they have a very normal, natural, way of healing. They're very happy with their results. They don't want to change their clothing, their bra. That second surgery in 15 to 20 years can be a easy 30, 45-minute outpatient procedure where we just swap the implant in and out. But I can't guarantee that it's going to stay exactly as is. Tissues stretch over time. There's aging from sun exposure, from other, health issues. That's my timeline where we need to take a look in 20 years. And I had a patient this week who was 40, and I was like, when you're approaching 60, let's reassess. And she's like, hey, now don't say that number, don't say that word. And so we kind of had a laugh about it, but it's important to sort of look at the long-term maintenance that's required, and knowing that your body may not look exactly the same 20 years from now. I don't know if you have anything more for the breast, or if you want to touch on the tummy tucks and some of the body procedures, even arm lifts, thigh lifts.
Yeah, I mean, they all follow similar themes, and kind of launches off of obviously what you're describing, is that our surgeries can reset the clock to a certain degree, but doesn't stop the clock. So aging continues, elasticity of the skin continues to get worse, tissue stretches, scars stretch. So when I'm going through my breast implant FDA form, one of the things is changes with age, weight changes. The vast majority of revisions, kind of like you're describing, are often to help correct age-related changes, whether the skin's looser, you lose more breast volume. That tends to continue to happen as you get older. Sometimes you gain breast volume during menopause, or when you gain weight. And the implants are often just fine, but we're often adjusting things during that time frame. With lifts, normally the general shape is pretty well preserved. Doesn't go back to where it started, but you might lose a little bit more volume. The skin stretches a touch, so it's not like it's goes away in 5 years, but it never stays as perky as it did at 1 week, 3 weeks. But again, normally the general shape, nipple position is typically very well preserved. So normally if there is a tweak, which again is relatively pretty low risk or low frequency, it's much smaller. Tummy tucks are kind of a one and done for the vast majority of patients. Again, will it get looser over the course of 20 years? Yes, but it's unusual to need a full revision or even a tuck up of the skin, because normally that things stay tight and the contours stay nice, assuming the weight's relatively stable. So it's kind of a pretty nice, very long lasting procedure.
So what if a patient asks, can you redo my tummy tuck? Are there parts of the tummy tuck that cannot be redone? Or what is commonly, we talked about breast revision surgeries and stuff a lot, but as far as a tummy tuck revision, what does that?
Yes, I mean, tightening up the lower abdomen with a big scar revision is certainly a pretty straightforward thing to do. If it's a little bit loose, I've seen patients that do need a full revision. If let's say they lost a lot of weight, or if they did the kind of a mini tummy tuck and it wasn't really done quite right. But
what about the muscle repair?
That's pretty unusual to need that redone. I mean, that's normally once that muscle is put together, it doesn't, stretch out very commonly, again, unless you've gained a lot of weight or had another pregnancy. I think that'd be pretty unlikely.
And then another visual that I give patients who are coming in for their revision surgery, they've had implants in for 15 to 20 years. They want them swapped out. They don't like how they look. They're wondering if they should be bigger, smaller. Is that oftentimes I point out that their implants actually haven't changed or moved very much. They're still where they're supposed to be. The breast tissue has descended or drooped down, become tonic. And that's what we call that waterfall effect or that Snoopy boob, and sort of point out to them, well, if we pull the breast tissue back up to where it's supposed to be, that can give you that semblance of having a larger breast. If you still want to upsize with the implant, we certainly can do that as well. But it's helpful because I think everyone's expecting the implant itself, everything just to go down. And oftentimes the unnatural implant stays exactly where it's supposed to be. And it's the rest of the tissue that's aging as opposed to the implant. Not in every case, but that's something that to me helps to understand what it probably looked like 20 years ago, and then how the clocks and hands of time are affecting the plastic surgeon's results.
Right. And I kind of alluded to this as well. I think the last question we're going to touch on here is weight fluctuation. So someone comes in for surgery, they want a tummy tuck, and let's say they're 10 pounds from their goal weight. What's going to happen if they lose that weight after surgery, or what happens if they gain weight after surgery? How do you kind of educate patients on that concern?
Yeah, my memorized robotic brain all like just jumps into rote memory, and I say plastic surgery is not a weight loss tool. It is a reward for the end result. Ideally, you want to be at your goal weight. You want to be at your goal weight for at least 4 to 6 months. You want to be healthy at that goal weight. If you plan to lose or gain over 10, 15 pounds, you should wait to have your surgery. Things happen. So there's stressors, there's life events, there's health issues that can change. And so if you are looking at some of the unpredictability of the future, if you were to lose additional weight, typically over that 15-pound framework, you may have more laxity in the tissue, that tummy tuck may not look as taut and as tight, as svelte as it did. If you were to gain weight, similarly, there's fat cells there will be some growth, there will be some enlargement, it will disrupt some of the results. Interestingly, I've had some patients in the last couple of weeks who've lost significant weight, and it has not affected their abdomen, their breasts as dramatically as other people, even above 75, 100 pounds. So I do think that there is a significant genetic component. It is quite patient by patient. It's not an all-encompassing answer that we are providing, but those are the key statements that I say. Dan, follow-up, questions for you. What do you tell them about weight changes up or down? And then another question that we hear about or get a lot is, well, once I don't want to do liposuction, or don't do any liposuction on me, because that just means when I gain weight, I'm going to get fat in all the other spots that I didn't have liposuction at. Like, how do you debunk some of the myths about the fat regrowth and regeneration and, what we sort of find online incorrectly?
For sure. I'm a little bit more flexible with like 15, 20 pounds. I think a lot of patients come in, they're like really close, they're kind of stuck. They've like lost a lot of weight, but they're just kind of, at this point where that skin is getting in the way. So if they're within 15, 20 pounds, I'm like this, and they're stable and they're kind of motivated, and I think they can still get a great, if their BMI is reasonable, get a great result at that weight. And then, maybe they do lose 10, 20 pounds afterwards, but it tends just to make everything look better. So I think that 10 to 20 pounds is, I'm a little more flexible than I used to be about it, because, I think it's most, especially tummy tuck results, are pretty durable within that range. And I've had one patient lose like 50 pounds. A lot of it was visceral fat, and she looked fantastic afterwards, was not loose. So, that's what we were taught. And
what's a reasonable BMI?
I mean, I like patients less than 32 for sure. I prefer, if lower you get, the better result you're going to get. But sometimes you certainly do get stuck. So I think, if you can get to 28, even better, 26, 24. Obviously, at certain points, it can be kind of tough to get lower than that, or if you've lost a lot of weight. But, it all kind of depends on the whole, BMI is just a number. It's not a great tool, but depending on how that kind of weight distribution is, height and things like that. So you got to kind of take in the big picture of things. But yeah, I mean, the fat, liposuction, fat distribution stuff. I think if you do liposuction evenly and more in a more cohesive manner, which I really like to do 360 liposuction with tummy tucks, then you're kind of treating the whole circumference of the abdomen trunk. You're going to then gain and lose weight more evenly. I think the problem comes in when people go do we talked hammering on under local liposuction. You just do liposuction or local, and you can only target like the easy to numb areas. They get all the fat in one spot, they thin it out, there's no fat left over. Well, then you're going to get kind of weird distributions because you have more fat elsewhere and really thin fat layers in some areas. So it's pretty easy to avoid that if you do the liposuction in an even kind of distribution. You're going to gain weight a little bit everywhere. You're going to lose weight a little bit everywhere. So treating the whole body kind of cohesively is going to be more effective for that.
Well said. Those were some great, very frequently asked questions that are often on their minds. They say at their first visit, their second visit, they say right before surgery, they're in the preoperative bay and they're freaking out and nervous. And these are just important reassurances that we give patients. It's healthy and normal to have nerves leading up to surgery, even though it's elective. These are safe. There are protocols behind them. Anesthesia is safe. Pain is tolerable. We can get you through it with the protocols that we use. The results are often long lasting, but not permanent, irreversible. They don't transcend the age of time limitlessly. We can achieve natural results if that's what you want, but we need to know what natural means to you. So really meeting the patients at their zone, and then weight changes can affect, but it can be variable from person to person. And so really each individual case would have that discussion with them. Any final points, Dan, for our Q&A sesh?
No, great session. A little over a 15-minute goal, but gotta cover it.
Yeah, I'm exhausted.
All right. Well, we'll have more coming out soon. As always, give us a listen, follow. Let us know if there's topics you want us to talk about. We definitely will try to hit those up. We'll be back next week or 2 weeks.
Have a great day.
See ya.
Thanks so much for tuning into this week's episode of Fuller Butz, a behind-the-scenes plastic surgery podcast. Doctors Fuller and Butz are so appreciative of your time and attention. We invite you to subscribe, share, and continue to enjoy our plastic surgery perspective. Feel free to reach out on Instagram at either @FullerSurgeryMD or @DanielButzMD. That's Butz with a Z for comments, suggestions, and support. Remember, be artsy, stay scientific, and make life fun. We hope you'll join us again on the next episode of Fuller Butz.